Welcome everyone to this second regional webinar of Global Mental Health Peer Network. I will ask Charlene, who is the founder and CEO, just to tell us a bit about what Global Mental Health Peer Network is all about before we carry on. Thank you, Charlene.
Thank you, Angie. I'm going to share a presentation just to make it a bit easier to see what the peer network is all about. But thank you very much for joining this webinar hosted by our Africa region, who's quite active in the field, raising awareness and destigmatizing mental illness and mental health. So I'm just going to give you a brief overview of what the peer network is all about. So we were established in 2018. So there's two main key focus areas that we focus on, and that is developing global lived experience leadership. And secondly, to create a sophisticated platform for people with mental health conditions where they are able to share their views, opinions, perspectives, and experiences. So yeah, at the moment, we are at the global office, which is based in Johannesburg in South Africa. We are 3 staff members at the moment. It's myself, the founder and CEO, then Claudia Sartor, who's our deputy CEO, and Zach Marta, who's our project assistant. You don't need to look at all the text over there. That's just kind of how we divide the work and our focus areas. What I want to jump into is this slide, just to explain our overall structure. You'll see like we have the Regional Executive Committee, and this webinar is specifically from the Africa region, and it's led by Mary Abanga from Cameroon, and Angie is our deputy from Zimbabwe. Then we have country executive committee, and those we appoint up to 5 people with lived experience to represent their respective countries. We also have subcommittees at the moment. So far, we established a research subcommittee, a youth, LGBTQ, and soon will be up and running is a family and carer subcommittee. Now, those subcommittees are there to kind of strengthen the voices of these particular areas within the mental health field. And then we have honorary mentors and honorary membership. So the work that we do, so yeah, you can see how we do our work, and our vision is to strengthen lived experience voices. So we empower people with lived experience. We unite lived experience voices, so we collectively strive to kind of active for action and advocacy initiatives, and then we enhance lived experience engagement and involvement at all levels, and that means policy as well and strategic planning. So why are we doing that? Is we are building a cohesive and responsive lived experience community. We ensure that lived experience voices are at the center of policy and practice, and we aim to include diverse experiences and perspectives to reflect in policy and practice. As you know, with lived experience, we're from all parts of the world, all parts of community, from various backgrounds. So that is very important to be included in our activities. And if you're interested, like I said, we appoint up to 5 per country. So far, we're represented in 34 countries. And we are looking for more representation of lived experience. But you can always go to our website and you'll find the application forms and application documents there. Then you can also follow us on social media. We are quite active on Facebook. We're on Twitter, Instagram. We've got a YouTube channel with loads of videos that you can watch, and also on LinkedIn. And there's our website address. And I think, Angie, that is it from me about the peer network. You can continue.
Thank you, Charlene. All right, we'll have Marie, the head of the Africa region, say a few words. Go ahead, Marie.
Yeah. Hi, everybody. This is Maria Abanga, and I am the regional representative for Africa. So I really just want to welcome you all to our second regional webinar on human rights abuses of persons with a mental health condition. We in the Global Mental Health Network, in one way or the other, we all have lived experiences, and it doesn't matter if you've had a formal diagnosis or not. So greetings, distinguished speakers, my able and most reliable Deputy Angie, ladies and gentlemen who grace us with their participation. As my CEO, our CEO just explained, the GMHPN is a platform for people with lived experience with a mental health condition to share journeys, experiences, perspectives, views, and opinions, embracing our humanity, appreciate our diversity, and uniting our voices towards achieving our common goal, which is for better rights, better policies, better advocacies for people with mental health conditions. So I'm honored to be the regional representative for the African region. So the International Bill of Human Rights was the name given to UN General Assembly Resolution 217/3 and two international treaties established by the United Nations. It consists of the Universal Declaration of Human Rights adopted in 1948, the International Covenant on Civil and Political Rights, ICCPR 1966, with its two optional protocols, and the International Covenant on Economic, Social, and Cultural Rights. The two covenants entered into force in 1976 after a sufficient number of countries had ratified them. Bear with me, I'm also a lawyer, so we talk like that. Okay, the Universal Declaration of Human Rights is an international document adopted by the United Nations General Assembly that enshrines the rights and freedoms of all human beings. I underline that. It was accepted by the General Assembly as Resolution 217 during its third session on 10 December 1948 at the Palais de Chaillot in Paris, France. Of the 58 members of the United Nations at the time, 48 voted in favor of the UDHR. The question I hope we have a clear answer to by the end of this webinar is, are persons with a mental health condition human beings? Are they part of all human beings? Because if they are part, why do we find that their rights, their human rights are violated, especially when they are going through any crisis? So we are very grateful to have psychiatrists with us. We are grateful to have our CEO who has extensive experience in mental health advocacy on national and international stage. And we are hoping to have Dr. Florence from the WHO. So we didn't choose this topic now par hasard. We all know and will be hearing how the human rights of persons with a mental health condition have been abused before the infamous Bedlam institution in the UK, right up to our days, and how in our continent, Africa, when mental health care is still so desirable. The COVID-19 pandemic and its complete shake-up of our lives as was is made us with lived experience think about our peers who might not have a voice because they have been so abused and will still continue to be abused. For after all, no one cares and no one can do anything. So hosting this webinar is our own way to care, to speak up and speak out, to hold space and to hold stakeholders accountable. Ignorance of the law is no excuse, it goes. I'll be listening from the resource speakers with rapt attention. Thank you very much. Over to you, Angie.
Marie, I would just like to welcome everyone again, and for all those who joined before we started, welcome. My name is Angelica Mkorongo, as has been mentioned, and I'm the Deputy Representative for Africa at Global Mental Health Peer Network. I'm a person with lived experience with obsessive compulsive disorder. And I'm also founder of Zimbabwe OCD Trust in Zimbabwe. And for now, just a few housekeeping issues. Dr. Florence Baingana, welcome, and please go ahead with your presentation.
The overview of my presentation is I'm going to, because when we talk about abuses of people with mental disorders, we need to think about why do the abuses happen. I don't think people wake up and choose to abuse a group of people. I don't think so. So we need to understand why these abuses happen. And so I will go into a bit of that background before I then get to what it is that we can do about it and what WHO does. I want to first talk about the burden of mental disorders in the African region, because that leads to what are we doing about the burden and as countries, and then where are the gaps, and those gaps are the ones which lead to the problems that we have, the abuses that happen in psychiatry, I believe. So the first one is the very high burden of epilepsy, and Lesotho, Cote d'Ivoire, and Equatorial Guinea are 3 countries that are in the top 5 for epilepsy globally. If we look at global numbers, then I present one slide that has the data for the top 15 countries, looking at both sexes, looking at males only, looking at females only. Africa has one of the highest rates for suicide. It's actually the highest rate for suicide globally. The next slide then looks at the global burden of, the burden of alcohol, heavy episodic drinking. That is one problem that we have. So as a region, use of alcohol is not very high compared to other regions of the world, but we have the alcohol industry targeting younger people 15 to 19 years old. So there are countries where we have even over 95% of people 15 to 19 years who drinking heavily, frequently, which is a very, very big risk factor for many other problems. The next slide shows the prevalence of alcohol use disorders and dependence, which is a big problem as well in the Africa region. And then I have a slide on countries with high prevalence rates of depression, with depression in the countries. The first 5 that I look at are Cape Verde, which has the highest rates, Lesotho, Ethiopia, Botswana, Uganda, and South Africa. These are some of the countries with the highest rates of depression in the region. The average rate of depression globally is 4.4%. But for the Africa region, we actually find those countries I mentioned, all of them having above the global average of 4.4. So in Cape Verde, for instance, they have an average of 4.9, which is almost 5%, a very high rate of depression. The other condition we look at is epilepsy, because in the Africa region, once you say mental disorder, they often include also the epilepsy. So that is another problem that we have. Let me try loading it from somewhere else. I think I have a big problem here with my, Anyway, I will continue because it's not going to work. So I will continue, and the slides will be shared with you all later. The other area I look at is neurological disorders at primary healthcare and at tertiary level. And the biggest contribution, of course, is epilepsy, even at the primary care level. Africa and South Asia are the 2 regions of the world that have very high rates of epilepsy, because the other regions, the higher income countries, have been able to control the causes of epilepsy in these regions. But for our regions, because of the poor quality of care and the poor access to healthcare services, you find that you have high rates of epilepsy. For instance, if a child has malaria, which is very common in our region, and the child has a very high fever, if we don't control that high fever, they can get febrile convulsions. And if those febrile convulsions are not properly controlled, then we end up with a child developing epilepsy. So these are some of the other issues we do with, like reproductive and maternal health services. If women don't attend antenatal care, therefore, problems are not predicted, you end up with the woman going into a difficult delivery, anoxia, it leads to epilepsy. So then I present a slide that shows that it is not one disorder. When we say mental disorders in Africa, it is not one condition like you can say HIV, you know. It is many conditions. We have the mental disorders, which by themselves are very many. We have OCD, which you know very well. We have anxiety disorders. We have depression. We have the psychotic disorders. Those are the mental disorders. Then we have the developmental disorders. And as I mentioned, in Africa, we tend to treat epilepsy in the same grouping with mental disorders because that's where people often come. And we include alcohol use, we include substance use, we include psychosocial disorders. So all these conditions together, you can see it's a very complicated area of work. And the causes of the disorders are also very many, and they are very prevalent in our region. We have wars, conflicts, we have floods, earthquakes, all these things lead to anxiety, depression, psychosocial disorders. Poverty, displacement, we have HIV and AIDS. We also have NCDs. So, you know, if you have a chronic, if you're diagnosed with cancer, for instance, that is very often going to lead you to become, you know, very stressed, very anxious. Some people develop depression. Even communicable disorders like diabetes, communicable disorders like TB. And then I mentioned the poor health systems. We have gender issues, sexual gender-based violence. So we have very many causes that lead to the high burden. The next slide then looks at the burden of disease and compares it to how much are we allocating to the management of all these conditions that I talked about. So most of the African countries, unfortunately, have a fairly high burden, as I talked about, and yet the allocation of resources is very, very low, very low. So that is a big challenge that we have. So we then go through the different areas of allocation, which you'll be able to look at, which I will not dwell on too much, but the different, when we think of allocation, we think about different aspects. For instance, if it is included, whether countries mention it in their policies and plans, and whether when they do mention it, do they actually allocate anything to the mention of, if you mention we need to be funding mental health, do they actually allocate resources? And we find that only 27% of countries are allocating resources. We look at how much is allocated in the African region, and it's about 10 cents per capita, 10 cents per person per year allocated to mental health on average in the Africa region. So you can imagine, this is US cents. You can imagine how much then would that do? And this varies country to country. So we have countries that allocate 5% of their budget, like Nigeria will allocate 5% of its budget to mental health, but other countries are actually allocating 0. So you find that most of the payment for mental health services is actually made out of pocket. People are paying out of their pockets for mental health services. So now, just like yourself, if you're going to go into a shop and buy something, you then make the determination as to what it is that you are going to pay for. So people often choose to pay first the traditional healers and the faith-based healers. So first of all, it is about the knowledge. What do they know about the condition? Where do they believe it should be treated? It is also where are the services. So as I mentioned earlier, we don't have very good coverage of services. And so people then choose to go to where they believe the services are for the condition they believe they have. And because they are paying out of their own pockets, that is where they pay. So even those who go to faith-based healers, where you go to pray, we all know that this service is not provided free of charge. Even if you go to a church or a pastor or wherever, it is still, you do leave some money there. The others is the traditional healers, and money is also left over there. So that is something we also need to keep in mind when we are talking about what quality of services are being provided. The other area I wanted to touch on was if we want to make services accessible, and that is the efforts that we are making as WHO. How do we make services accessible to the people? We provide them at the community level because that's where the majority of the people are. And we provide them at primary care level. That is the next level where we want to provide services. And yet for the Africa region, the community level has the lowest coverage of mental health services. One reason is that governments are not investing in mental health. When they do invest in mental health, they invest in institutions. So 90% of the budget that is allocated to mental health, maybe 60, 80, 90% goes to the institutions. It goes to those big hospitals, and then the rest goes to maybe secondary care. And very little trickles down to the primary and the community levels. So that's another big challenge. Often when we talk about community care, we are often thinking of structured service. In some parts of the world, it's a very structured service. You know where you're going to go when you're going to a community care facility. It's very many countries, it is actually a facility where you have others working together, both healthcare and social welfare working together to provide the service for the individual who needs it within the community setting. So they may help you with getting a job or going out into a protected work, what do they call it? Workplace. Some people get compensation for the number of people whom they employ who may have a disability. So there are these kinds of things that can happen in some parts of the world. But unfortunately for us in Africa, when we say community mental health care, very often it means the burden is put on the family. And when it is put on the family is not provided any kind of support. No capacity building for how they can help their person who may have a mental health condition, or no resourcing of those services within the family. So there was a study done in India where people were comparing institution-based care, the costs, with giving a small amount of money to families to look after people with chronic mental health conditions. And they found that it was actually cheaper and much more humane to have the people with lived experience in the family if you provide a little something to the families. But unfortunately, our governments cannot afford or do not choose to do that. Yeah, so we have tried institutionalization, for instance. Sometimes when it comes as a wave and people say we need to deinstitutionalize, which is a good thing. But unfortunately, how it is done is important. So if you decide to deinstitutionalize and the funding that should be going to look after that person with a mental health condition in the hospital should then be transferred to the community services. But often when we deinstitutionalize, it is only the patient that is moved into the community, and the funding does not move with them into the community services. One example we have is in South Africa, where it was done very rapidly, and the people moved out of the institutions into community care facilities that were not very well regulated, not very well managed, not supervised, and unfortunately, a number of patients died, and a commission had to be set up. So we have to be very careful when we say we would like to have our people with mental health conditions in the community, yes, but how is it done? Because in trying to do it too fast, again, that can be another way that abuse happens. That was one area, and the other area I will be talking about. How many minutes do I have? It's about payment. Who pays? And I've talked about people paying out of pocket, but when we go into community care and paying of community health workers, families are not going to pay community health workers. Families prefer to pay a doctor or a trained professional, a nurse, you know, or a clinical psychologist or a psychiatrist, but families very rarely will pay out of pocket to a community health worker. And many of the community health workers are non-remunerated. So if you have non-remunerated workers, what quality of care are they going to provide? So that is another challenge that we have. So just to summarize the challenges, I will say that most countries, one other challenge that I did not mention is many countries in our region, unfortunately, do not have legislation. Those that do have legislation, many of them, it is outdated. So if it is outdated, it means it does not align to the Convention on the Rights of People with Disabilities. So that means you may have the legislation, but that legislation, like for instance, the one in Sierra Leone mentions, it's called the Lunacy Act. So we can imagine what sort of legislation that would be. And yet it is recorded in the books as they do have legislation, you see. So there are those kinds of problems. Service coverage, as I mentioned, is a problem. Most of the services are in the bigger cities, in big institutions, very little in the communities, in the rural areas. Funding is very low, and the majority of funding to mental health is actually paid out of pocket by the families. And therefore you find that when a family has somebody with a mental health condition, it becomes impoverishing for that family. And then families often begin with faith and traditional healers. So those are some of the main challenges. So what is the WHO response? And these are three main responses. One is the WHO Quality Rights Initiative. This initiative is about, it has an anti-stigma component. It has increasing knowledge about mental health conditions, but it also does a lot of advocacy for human rights. And this initiative is already initiated in Kenya and in Ghana, and will soon be initiated in Zimbabwe. So we have already begun discussions there. But anybody who wants to do that, it's an e-training. Anybody who wants to do the e-training, they can do that. They can request for the link, and they would be given a password, and they can do the e-training. But to formally introduce the quality rights as an initiative in a country, we would need to do that in a more systematic manner. But we encourage as many countries as possible, as many people as possible, to do the e-training. In Ghana, over 9,000 people have done the e-training. And in Ghana, before you work in, and in Kenya, I believe as well, before you work in a psychiatric institution, you need to show the certificate that you have done this training. The second area is support for revision and development of policies and plans and legislation. So if we can revise policies and plans and legislation, and if these are revised and in partnership with WHO, we are likely to say, we will ask the country, is it aligned to the convention, CRPD, Convention on the Rights of People with Disabilities. So any policy that is being developed from now on, when we do the review, that is what we are looking for. But at the end of the day, the decision is the country's to pass a policy or a law. So very often we make suggestions, but the country is the one to make the final decision. And then the last area is strengthening of mental health into primary health care. So as I mentioned, it is one of the biggest challenges we have is access to quality care. So if we can strengthen mental health at the primary and community care, then we would have at least, we believe, gone a bit of the way to prevent some of the abuses that happen at those lower levels of care. So thank you very much. I'm very, very sorry about the different problems that we had, yes. But hopefully you'll get the slides because I sent them out. So thank you. Over to you, Angie.
Thank you, Dr. Florence. That was quite insightful. And I'm seeing lots of messages in the chat box where people are really thankful for your presentation. Due to our time, we are not going to go into questions now. Let's go to the next presentation, and then we can have questions at the end. Our second speaker is Dr. Nemache Mawere, and he's going to tell us about the Zimbabwean experiences on the abuse of people with psychosocial disabilities. And just a little about Dr. Nemache. He is a psychiatrist and acting CEO, and also consulting psychiatrist at Ingutsheni Psychiatric Hospital in Bulawayo in Zimbabwe. He's a lecturer and acting chairman at the Department of Psychiatry, National University of Science and Technology. He is a visiting psychiatrist at Mlondolozi Forensic Hospital at Khami Prison and at Chegutu Medical Center. And finally, he's also involved in a project dealing with common mental disorders amongst children and adolescents in Zimbabwe. Whew, what a mouthful. Okay, Dr. Nemache, the floor is all yours.
Thanks, Angie. Good afternoon, everybody. You didn't say what I do. I do much more than that. I just gave you a little bit. So never mind. So I've been asked to talk about the abuse of people with psychosocial disabilities in Zimbabwe. Are you able to share my slides? So,
would you like me to share your slides?
Yes, I network challenges, so I couldn't share, but if you can share for me, that would be good. So I would start by saying mental illness is variable from the subtle emotional dysfunction to the gross and apparent manifestations, which are obvious to everybody. And society tends to react differently depending on the symptom severity. Also, the reaction depends on whether one is admitted or is in society at large. You need to move the slides down. Sometimes the reaction of those attending to the patients can be very adverse, but the aim is to balance the safety of society or a caregiver and also patients' human rights. Move them down again. And there are evolving care patterns which demand that service users have more input into their care, and they can actually come out and report abuse, which they previously experienced, but were precluded from reporting. Because the problem is people always who live a psychiatric patient. So people tend not to want to report. Can you move down the slides again? People tend not to want to report because the psychiatric patient, nobody wants to believe psychiatric patients. Unfortunately, there are no figures available for Zimbabwe situation, but evidence exists that there is actually a lot of abuse of patients which is going on. And to an extent, the perpetrators get away with it. So what happens in institutions? According to the next slide, please. According to the current Mental Health Act of 1996, which is quite outdated for Zimbabwe, it actually promotes institutionalization. With admissions, people who can be admitted for prolonged periods. We have an interesting case here at Ingutsheni of a 102-year-old man who has been admitted since 1952. So people tend to be institutionalized and nobody really worries about it. There are lots like him here, but that's just an example. And most of my patients, I would say 3/4 of the patients here at Ingutsheni, they've been here for more than 5 years. So that just goes to show that we are actually more comfortable keeping people in hospital than looking after them in society. This act also has a provision for voluntary admission, but the option is rarely used. Maybe people actually are not even aware of it. There are very few people who are aware of it, that actually you can be admitted voluntarily, and then you can ask, actually, if you have voluntary admission, then you can ask actually to be discharged when you think it's time for you to be discharged. But if it's not the case, then you have to stay here for the rest of your life. And usually they find the patients who get admitted, they already have their pre-existing trauma, which usually may be the cause of the psychopathology. But this is not addressed. This focus is on the control of the acute symptoms. So when you are acutely ill, nobody's worried about how you ended up coming to hospital, what really was going on at home. People are just managed as acute patients, and they are usually put under regular and heavy sedation, which actually, and they sometimes actually put in seclusion, which is a favorite for most of the staff, because when the patients are put in seclusion, then they are quiet and they are away from, they are heavily sedated, they're in seclusion. Whatever medical problems they may be having there, anything can happen whilst people are in seclusion. We have lost 1 or 2 people in seclusion because of that. Because actually sometimes someone can have a head injury whilst they are in seclusion. Because they bumped themselves before they got admitted and nobody noticed it. And then it gets complicated, and then before you know it, someone is already going down. And then we have lost 1 or 2 patients that way. And sometimes people don't have time to listen to the patients. When the patients are trying to tell them their story, that actually there were problems at home which made me to become admitted. Nobody's listening to that. All they want is just to say you're making noise, just get into the seclusion and get sedated so that you are away from, then the people can have their peace. And sometimes also there's violence from fellow patients. I had a patient I admitted last week from Charlene. This young guy had alcohol and he was misusing also methamphetamine, crystal meth. And then the young guy says, no, I don't want to stay here because I'm just getting beaten up because I'm so small. He was small and fragile and was withdrawing from the crystal meth, and he was really in a difficult physical condition. But he was getting abused by that patients, and nobody, when they are all locked up in the ward, nobody saw what's going on when the doors are locked up. So there's physical abuse, there's verbal abuse as well, and sometimes other patients who are not strong enough can have their food taken away from them by the stronger patients. And there's also been episodes of sexual abuse which has happened among male patients who are admitted at the same time. I know at the prison is quite a big problem, but even here at Ingutsheni, we have had to send patients off to Mlondolozi when they have sexually abused fellow clients who are admitted together with them. And also the living conditions may be very congested and not conducive for recovery, because you are really wandering, and then there are also other things because of the congestion. There may be problems of lice and lack of water when there are water shortages, and then lack of other amenities. Then we've got more problems there. So someone is really having their rights trampled on in that kind of place. Coming to forensic institutions, where I happened to work for about 5 years of my life, I was there working. I'm still going there, but initially, when I came to law, I was working at Mlondolozi. You find the staff, they tend to give patients these names, referring to them as people of low intelligence, people who don't know what they are doing. That's why they end up here. So the name calling can be a very big problem, which is being done by staff. Unfortunately, for our situation, our staff who are looking after the patients happen to be more of prison officers than the nurses because of the staff shortages. You find the prison officers, they are the ones who spend more time with the patients than the nurses. And so sometimes when the patients are not really understanding, there's a misunderstanding, there's physical violence perpetrated by the prison officers themselves or also among the patients themselves when someone is causing problems. I remember a very interesting case of someone who had mental retardation and they were keeping him for observation, but the patients, other senior patients, were getting some chlorpromazine tablets from wherever they got it from, and they were giving this patient, and then this patient would be sedated, and then the guys were always sexually abusing this patient. And when we was talking to the patient, then he tells me, I'm actually taking this medicine, these white tablets. But I said, you're not supposed to be taking tablets, you're under admission, under observation. But then it was because of people who actually had access to these things and they could do those things to the other patients. So violence from fellow patients can be a real big problem we have. We have lost some patients. We have actually ended up murdering each other because of staying in this kind of institutions. People can bring in other things which can, injure someone, and then you can actually lose a patient. We have lost a few patients within our institutions because of violence from fellow patients. There are not enough healthcare workers, as I have already mentioned, under the prison system. So we're actually training our prison officers on the Mandela rules on how to look after the patients under their care, so that at least they would give better care to the patients. But unfortunately, because of the high staff turnover, they keep changing places of work because the prison system does not allow people to stay in one place for a long time. So when you get new staff, you need to train them again. And now with COVID, training has gone on for more than a year now because we can't be gathering together to do it in crisis mode. So you can imagine what is happening now when people have worked elsewhere and they've always had this feeling about patients, then they are suddenly brought in to look after these patients. They know that the only way you can talk to mental patients is just beat them up and put them in seclusion. They don't really know about de-escalating procedures and things like that, which we have been teaching the other ones who came before. So it becomes a problem in itself. And also because of delays in the special boards and mental health tribunal, the discharge procedures are actually very prolonged. So this causes chronic distress and powerlessness. You can imagine someone has been there since 2008. And within families, sometimes families, there's a lot of violence and adverse childhood experiences going on. A lot of expressed emotions. I'm told my time is running out. I would like to explain what is expressed emotions, but there are lots of high expressed emotions within families and also low expressed emotions. And the family support can be very poor, including the extended families. And also the abuse, we can keep talking about the physical, verbal, and emotional and sexual abuse is also quite prevalent within families. And patients are actually denied opportunities to attend school or work or even start a family. They are not allowed to go through all those procedures. So the family wants to keep their dignity, and then they keep these patients inside their home. And sometimes, actually, it's because families have no knowledge of what to do. That's why we end up with these problems. And in our communities, people strongly believe in the issue of Ngozi, which is the avenging spirit. If you kill someone in your family, kill someone, then all of the people in your tribe or clan will end up having some form of mental illness. So it can be said to be a cause of mental illness, but sometimes it's all because of hereditary issues. That's why people develop this mental illness. So people tend to abuse these people, and then they are made to go around the community, putting on regs and all sorts of things, asking for forgiveness from the community. And then people end up getting mocked and they're made a symbol of ridicule within the communities. And sometimes also the hospitals, the frequent stockouts of medicines, which is a big problem. Like Dr. Florence was talking about the mental health budget. Only 1% of our health budget is allocated to mental health. So we always have stockouts of medicine. So it causes a lot of problems. Our mental retarded patients are also at risk of sexual abuse. As we speak, I've got a long queue of people outside who are waiting for me, who have been sexually abused because of their mental situation. So they actually getting sexual abuse. I have to assess them for the courts. So it's something quite prevalent in the community. And sometimes we don't even know what to do with it because the people will not be able to identify perpetrators. Perpetrators get away with it and nobody is going to know what really happened. And sometimes the perpetrators can actually be people who are staying with these people in the same house. So, a lot of misappropriation of or earning some good money. People take your money and then the rest, they'll tell you that we're actually using biomedicine that they are spending on whatever they want. Our people, they have lots of livestock, which they also used to keep. And once you develop mental illness, then your livestock and your pension and everything can be taken away from you. And sometimes people actually get falsely accused of crimes which they never committed because they cannot be able to speak on their behalf. Someone can just be said, you committed this crime of rape, if it has been reported in the family, or you murdered this person when they didn't even know. When they come to Mlondolozi and they're trying to talk to them, they'll tell you, I didn't do it. And they keep on telling that they didn't do it. And sometimes you end up believing them because they really didn't do it and nothing points them to having done it. But the very same member of family who is actually coming to do the affidavit is the same one who could have actually committed the crime. And they are pushing it towards this person with the mental illness, and then they end up getting incarcerated for no apparent reason. So what's the way forward with all these kind of problems? I would like to push forward an agenda that we should increase awareness programs and foster a caring attitude among families and society. And also we need to regularly train our prison officers who are looking after the mentally defective offenders on humane treatment of clients. This is a very big problem which we really need to work on a continuous basis. As I said, it's unfortunate because of the COVID, the things have been slowed down a bit. But that was one of my achievements when I used to work there full-time at the prison, to make sure the prison officers get trained in this so that we would all look after our patients in a better manner. And also still appeal to the authorities to enact progressive laws which protect the rights of mentally ill patients in hospitals, prisons, and the community, and not promote this issue of institutionalization, which is more of what we have in our kind of mental health act at the moment. I hope with the WHO initiative, this area is going to be looked into. I thank you.
Thank you, Dr. Nemache. Mawere, that was, just listening to that, it really sounds so, hopeless and scary. But at least we are trying to do something about it. Because of our time, I will just ask Mr. Mshunje just to give us a minute talk on how he was mistreated at an institution, so that maybe some of us can understand some of the things that go on there. Mr. Mshunje, are you there? Okay, I don't seem to see him. All right, maybe you can give us a comment at the end, but let's go on to our final speaker, who is the founder of Global Mental Health Peer Network. Sorry, I've just seen Mr. Mshunje. Mnyarazi, would you like to, yes, just a very short minute or so, if you can unmute your mic. Mnyarazi, can you unmute your mic, please? We can't hear you. All right, it seems to be having a challenge there. Are you able to talk, Mnyarazi? Big boy? All right, we'll go to Charlene. Charlene Sunkel, she did speak earlier on, but this is the founder and CEO of Global Mental Health Peer Network. And she's a global mental health advocate with lived experience with schizophrenia. And she has published internationally on issues related to mental health and human rights and stigma, and the needs of people with mental illness in low and middle income countries. Ms. Sunkel has been involved and provided technical assistance to national and international mental health related policies, reports, and documents. And of course, she has received numerous numbers of awards for her work. Please, Charlene, go ahead.
Thank you very much, Angie. I'll share my presentation. I think it was very interesting that previous two presentations speaking about really the shocking conditions that people with mental health conditions find themselves often within the mental health system itself. So I'm going to talk a bit about, I think, yeah, some visual images that you can see. This is still reality in many low and middle income countries. People are confined in inhumane conditions, segregated away from society or communities, receive no treatment. Often there's, I think doctor from Zimbabwe spoke about Stockouts medication. That's a reality even in South Africa at the moment with COVID, so it's a problem. And also these conditions in which people have to live within institutions is very degrading, and there's still chaining happening despite human rights instruments kind of objecting to it. Yes, there's some more images. If you go online, the Human Rights Watch published a report, I think it was last year, October, that shows these human rights abuses still happening in the world. They found that hundreds of thousands of people with mental health problems, including children as young as 10, are forcibly chained up in cages and kept in appalling conditions without medical help. So people often think, yes, people with mental health conditions, especially severe conditions, need to be locked up. They're more prone to commit crime and they're violent and aggressive. But actually, research showed that the prevalence of violent victimization in severe mental illness, 16% reported that they had been violently victimized themselves. It also shows that people were more likely to experience severe psychopathological symptoms, homelessness and substance abuse. And we heard from Dr. Florence as well how intertwined substance misuse is also an issue. And then also persons with severe mental illness were 5 times more likely to be victims of assault and 3 times more likely to be victims of household materialistic crime. I remember in previous occupations where I used to work with human rights violations, a lot of people with mental health conditions in South Africa were actually abused for their properties. For example, they inherited a property and then were kind of manipulated to kind of take the property away from them. That's abuse. So if you really look at it, people with mental health conditions face 2 severe problems. First of all, it's debilitating symptoms that they can experience from their mental health condition. And then secondly is stigma and discrimination. And stigma and discrimination can be much, much worse than the symptoms of a mental health condition itself. So if you look at human rights, if you look at human rights approach to disability, now that includes psychosocial disability, it acknowledges people as rights holders. And the discrimination and exclusion of people with disabilities are often related to social structures and policies that restrict and ignore the rights of people with disabilities. So the human rights approach, it doesn't look at the person like a medical model looks at a person as a medical problem, if you can say, something that needs to be fixed. A human rights approach look at what is required from society, but also from government to kind of create the necessary conditions for people to realize their full rights. I'm not going to talk, Mary already mentioned, she spoke in an introduction about the Universal Declaration of Human Rights. If you look at, it's been backdated to 1948. So human rights is nothing new. It's been in existence for a very long time. And in the declaration, it says all human beings are born free and equal in rights and dignity. I always like this quote by Paul Albert that says, "It is society that disables us, not our impairments." Shows you again that we are not, your mental health condition is not so much disabling you, but it's society, the restrictions, the discrimination and stigma that actually causes a lot of disability. Okay, so this is our social rights. I just want to go briefly through this list of social rights, and these are the rights that often quite commonly violated. Yeah, the image on the left-hand side, you'll see the difference between equality and equity. That's always such a nice depiction for me. Equality means everybody must be treated equally, must have access to equal opportunities. That would be work, whatever, education, all that. But equity means that you kind of give the person what they need to achieve. So social rights is equal and equitable social rights. For me, a very important one is full participation in all aspects of life. We heard from the two doctors previously about, I call it patients. I don't really like using the word patients, who don't really have the opportunity to take part in their own treatment and recovery plans. That is what the recovery model is also based on. The person needs to guide or lead their own treatment and recovery. And I'm not talking only about at a personal level in terms of that participation, but also participation at a broader level, being kind of participating in policies, influencing policies, help to develop and kind of redesign mental health and health systems, or not only health and mental health systems, but any other system that any person with a mental health condition uses to make sure that it kind of provides equity for that person to use. And then we have a list of rights, your usual rights about education, work and employment, healthcare, housing, transport, sports, recreation, culture, social development services, food security, and family life. Those are rights that everybody has, and that must be equal. And then building socially cohesive communities. That means people with mental health condition must form part of a community and must have access to participate at all levels within that community. And then improving education and health outcomes and building safer communities. Mainstreaming approach. Mainstreaming approach talks about, if you look at it from a mental health perspective, that would mean all these rights need to be incorporated in every sector. So mental health, for example, must also be, or the rights of people with mental health conditions must be incorporated across the board, not only within the mental health system or the health system, but also education, employment, and all those other aspects. And then development and empowerment. For me, this is a very important one. Just on the front of human rights, what I've discovered is, how do we actually know exactly how many people's human rights are violated? Because if you don't know your rights, or you don't understand your rights, then you're not going to know how your rights are being violated. So it's very important that people need to be empowered and informed about their rights, educated about their rights, so that they know when it's violated and also what resources are available to access redress for what happened to them. And then live a barrier-free environments within communities. That again relates to stigma and discrimination. And also you cannot be denied, let's say, for example, you want to go study further and they deny you merely based on your mental health condition. That is a human rights violation. And providing individuals required support with the means to participate in community life. That again comes back to the equity issue. So just in conclusion, so how do we actually move forward into a society that respects and protects human rights of people with mental health conditions? We need to create a stigma-free society that does not discriminate on the basis of disability. People need to see the person and not the disability. I think people always tend to see your disorder and they don't see who you are and what you are capable of. And then empowerment, like I explained earlier, and access to information. In my career in the mental health field, close to 20 years, I've come across a lot of people with mental health conditions who have very, very limited knowledge of mental health conditions, or even their own mental health condition, or mental health broadly, or human rights. I once did a survey, and I think that I found that above 80% of people did not know their human rights. So that's a shocking figure. So how do they actually know when their rights are being violated? And then decision making. And when I say decision making, it's important to understand the rights aspect of having not substitute decision making, like someone making a decision on your behalf. It's important that there's supported decision making. You still lead the decision making. You just have someone supporting you if you need support. And when there's supported decision making, of course, there need to be safeguards as well, so that nobody can abuse those kind of, when they support you in making decisions, they can abuse that. I know a lot of people had a lot of concern that families kind of make decisions on their behalf, just decide, just to get them out of the way, to put them in hospital, in a psychiatric hospital. So safeguards need to be in place to make sure that doesn't happen. And then platforms, and this is actually why I established the peer network, is to create a platform where people with lived experience are, of course, able to share their opinions, concerns, but also their needs. And for these to be taken seriously, and also to recognize the voices of people with lived experience. And then most importantly, like I said, at more at the systems level, people with lived experience must be actively involved. And by that, I mean meaningfully and authentically involved in the design, development, implementation, but also the monitoring and evaluation of services. And also service delivery in the format of peer support work, which is really an under-recognized field in the mental health field. And I think even in Africa doesn't really recognize peer support workers. So in conclusion, I think it's just important to end off with nothing about us without us is, for me, a very important statement. And I thank you very much.
I'm sure everyone here agrees with me. We have a lot of work to do. We have a lot of work. And I think it's very, very important that we realize that we, the people with lived experience, need to spearhead this whole campaign. We should go out there and well, let people know that, yes, you can thrive, you can live with a mental condition, because in certain cases, people are still in denial. People still don't think that someone with a mental health condition can actually strive, can actually do anything meaningful. So yeah, we have a lot of work. Before we go to questions, I'll just ask Big Boy Mnyarazi just to say a little bit on how his experiences at an institution. Please go ahead.
Thank you very much, Madam Mkorongo. My mental situation dates back to 2005, when I was a student at the University of Zimbabwe. I got diagnosed with schizophrenia, and I had to drop out of college because of my condition. I was admitted at the Annex. It's an institution that cares for the mentally challenged people in Zimbabwe, Harare, Zimbabwe. When I got there, I was abused by the security personnel that manned the place. They beat me thoroughly because, from what I've heard, people say I was like, I was very violent. So in order to control me, or to put me under control, there to beat me up so severely, you know, it was so painful. But I managed to stay at
that institution for close to a month. I told my uncle, who works in the Ministry of, it's the ministry, in fact, he is a police officer. So he approached these people and he told them what they had done was not good. But they tend to turn a deaf ear to his reprimands. They continued to abuse me whilst I was staying at the institution, up until a time when my situation or my condition improved. It was just so painful. You know, the kind of treatment that mental people are actually getting at some of these institutions, it's unbearable. So my mental condition improved and I was discharged. And sometime in 2011, I also got admitted at the annex. This time around, they were no longer abusive. I got assistance from my family members. They took good care of me. They would come and see me while to bring me all sorts of things, food and everything. But I just want to thank Ms. Mkorongo for giving me a platform to air my experiences as a person living with this condition. Fortunately, I'm currently employed in the Ministry of Home Affairs at the Registrar General's Department. I'm an assistant processing officer, stationed of one, married, 38 years old. What I just want to say is, may you please organize more of these webinars so that we get the information, we spread the word to people all over to know that a mentally challenged person is also a human being. Thank you very much, Ms. Mkorongo.
Thank you, Mnyaradzi. I think Mnyaradzi's story is nothing new. I remember I visited a home somewhere, someone's house where they had someone with a mental health condition. And they told me that the only way he sleeps is after they beat the person up. This was a 31-year-old man that was being beaten up to sleep. And that was really, really sad. And, you know, we really need to find ways to, you know, look at all these problems and find the best way that we can do it. Thank you, B-Boy. Thank you so much. I don't know if there are any pressing questions. How much time? We have just a few minutes, I think. If anyone has a question, and you can address any of the presenters. Anyone? All right, I've got a question here. This is from Eleni from Ethiopia. And she says, how can African mental health advocates and their stakeholders contribute to shifting the narrative from stigma-driven bias against persons with mental health lived experience to a more right-based approach that promotes care and services worthy of their human dignity? I don't know who can answer this. Yes, Charlene?
Yes. Yes, I think to go on the right track is to for us, it's lived experience to stand up. I think our voice is very strong, or probably the strongest. And I think we need to unite with one voice, speak on the same level, kind of the same message. And I think developing lived experience leadership is a good way so that we can change this perspective of us being kind of useless, but that we can play a very important role in the whole mental health and policy. Thanks.
If I may add to that, please, I just want to emphasize very much what Charlene has just said, because it can't be people speaking for others. I think the example of people with lived experience speaking for themselves is very, very powerful. A lot of the research that has been done, for instance, on stigma has found that when people see others whom they have feared in the past, and they see them interacting and doing things just like anybody else, then that stigma begins to go down. And so that is one way that we can, I think that is one way that we can work. It's really important. The other way, of course, and I will keep repeating this, is to encourage people to
Hello, Florence. Oh dear, I really wanted to hear the second point.
You will realize the things that we do that actually, just like that person with lived experience just shared, there are many things we do, including from the gate of the hospital. There are many things we do, but even within the families. So I encourage everybody to please do that quality rights e-training. That is one way.
Thank you, Dr. Florence. I certainly agree with what you're saying. Empowerment, we need to everyone, from the people with lived experience to the families, to the community, and even the government officials all need to be educated about this, because that is the only way as well that they will accept the fact that people with lived experience can actually strive. And of course, empowering people with lived experience is one of the most important things that we need to look at right now. Any other comments? All right, I see there's a question here from someone in Sussex. Oh gosh, okay. She says, what kind of training is available for peer mentoring, that is peer support for mental health? And what do you think might be needed at a local, national, or international level? And then she also says, I saw your Facebook page shared a recent study on peer support, but was wondering what the speakers here thought it needed for effective and successful peer support across African Union.
Yes, can I hit it off here, Angie? Yeah, thank you for that question. Yeah, we focus on peer support as well. We find we're kind of prioritizing that right now. I know peer support is available more in high-income countries. Yeah, I'm talking not about peer support groups. I'm talking about peer support work, peer-to-peer support. But the peer network is currently trying to secure funding to develop an online peer support training platform, which would be available, especially to low and middle income countries, for free. I know there are ones that's quite expensive, and of course, low and middle income countries can't always kind of afford it. And I think the training that we plan to do is also need to be adapted to the context. There's another research project that's Upside. It's called Upside. You can go and have a look at that. They're also working around peer support, so that's also quite interesting. Yes, and I think we need to convince governments of the important role of peer support workers. I mean, there's a lot of research around it, And I think it can address quite a lot of problems within the mental health sector in terms of gaps in human resources. It can also be quite a cost-effective method in providing support services within the community and really focus on a recovery model and human rights model. I hope that answers your question, but you're always welcome to email me directly to further the conversation, because I think we're running out of time. I'll send my email address now.
Dr. Florence, as we wind up, do you have anything else just to say? Any last words?
The last words are going again to the WHO quality rights, and I believe the power is actually in your hands. Governments will not strengthen mental health services unless there's advocacy for them to be strengthened. And the best place for that advocacy to come from is going to come from the people with lived experiences speaking up. We need to fight the stigma by coming out and speaking out. And the peer networks are very useful for that. You become empowered in how you speak out, in how you deal with the repercussions of coming out. It's like coming out if you are, so you come out and you speak out, but there are going to be repercussions. But the peer encourage people to come out and speak out. So I will just do that one very briefly. I think there was a question on services in Pino. In the prisons, and yes, there are mental health services in the prisons, but we can't go into the details here. And mental health and COVID, yes, there has been an impact on mental health services. We did a study. The link is going to be up on the WHO website. A study was done on mental health and COVID in the services, not the impacts, but the impacts are also there. So I will stop there because of time.
Dr. Nemache, any last comments? If you can unmute yourself, Dr. Nemache Mawere, we can't hear you.
Sorry, thank you very much. Now, I just wanted to say I'm happy that you as service users, you're actually very keen on this issue. We need to incorporate mental health issues into the primary health care programs so that at least we look after our people at the primary care level rather than waiting for the hospitals to intervene. Because if people are aware of what to do with their people in their communities, then it's actually better. It will cascade to the higher levels. And like if we want to make it a top-down approach, we will never really get somewhere. So we need to start doing lots of community work, lots of community programs. I'm quite sure it will help to remove the abuse and the stigma towards mental health patients. Thank you.
Charlene, any last words?
I think for the sake of time, I just want to say thank you for everybody, and thank you to the Africa region of the Global Mental Health Peer Network. You always do us proud. Thank you for organizing this.
Okay, thank you so much, everyone. And next time we are going to be looking at stigma. That is something that came out of this a lot, and I don't want to let it hang on for too long. So next month, hopefully, and with more guest speakers and lived experiences too. Thank you so much, Angie, for the moderation. Thank you, guest speakers. Thank you, Charlene. Thank you, everyone.